So next we're going to talk about patient-centered medical home. And the first slide we have kind of the methodology, all the things that kind of go into how do we start to solve these population health problems that we have. And we've mentioned many of them: enhanced access, team-based care, population health and management, quality improvement, population health and utilization, how do we plan and manage care better, how do we track and coordinate care, how do we measure and improve performance. And so those are a lot of the tenets we have when we think of what do we have to do to be successful as we go forward in the future. The reality is, a couple years ago I gave a presentation that was pretty theoretical. We were really practicing in the same way we've always practiced everywhere, and there weren't even sites where we were trialing new things or trying to adapt to the future. And so we came up with a kind of a theoretical plan and jumping off point. And now I think what I really wanted to show in this presentation today is the concrete nature of change and how this stuff is really happening. It may not be touching you right now, but what we're growing across the state of Indiana in an integrated system of care that can help the patient, but also help you guys take care of your patients and help that interface with the patient feel good and and also feel like the system is supporting you is the goal. So I want to show you this slide, and this is a busy slide, but this is the plan. So as you look at the bottom left-hand corner in that pie, you see the growing the pie of care or the number of patients under care. As we get our patients healthier, to keep our hospitals open, we got to have a bigger cohort of people to have the same number of people that are in those hospitals and keeping people busy. And same thing with our specialists, by the way, and that's what Rich was trying to explain. So we want to grow that pie. You know, everybody in the medical group takes every insurance now. We don't really separate by payer because we got to be open to bringing all these patients in. And then we design these new changes in care. We've added patient-centered medical homes, so we have 7 of those. Within that, we've gone up to 9, and within that we have more than 50,000 patients, 49 providers. We've added advanced practitioners. We've taken on what does it look like to be in a medical practice, and we'll talk about some of those things today. Medicare wellness, nurses and exams, daily huddles, extended hours. We address the compensation model to incentivize you to be involved in this. So as we looked at growing the access and where to put them, we also have to look at the ability to use data in that. And so as you follow along across risk stratification, you can see that we got to start to identify where are these people? Are they sick? Are they not sick? How do we code them? Do we give you your list of potential scores for patients or diagnoses for patients so we can truly identify who has risk in the population? And also, how do we use data in a wise way and deliver it to you? And I think you're starting to see that as that flows across. What used to be a theoretical slide with that scorecard is now a reality, and that's something we've worked to for a long time. You bring all those things together, and then that allows you to get to care management and quality that drives shared savings and a risk model. So then we can go, instead of having to succeed on ever-changing goals from payers, we can say, hey, give us a PMPM, we agree on what that is for this risk-based population, and we'll manage it and be successful. Because until you get to that point, I can tell you in working with the payers, the goals change every year. And it's very difficult to keep up with that next thing until we get to risk. So, you know, I sit in meetings now where we do talk about, you know, when does the pendulum finally flip over, and there's a lot of people who feel like we're getting close. So that all to roll up in the plan of where we're going gets pushed into how do we deliver it in primary care. And so this is that same slide that we've looked at for a while. When we look at your left side of this slide, you see the traditional medical home. Physician, we've augmented it with advanced practitioners and enhanced collaboration to try and have that team work as a group. Your MAs working to do more things and having defined roles, doing those enrollment forms for you, running your reports or calling your mammogram patients, and then your PSRs being involved in, and patient service representatives being involved in different ways. And so And they're now doing different things like having standard meetings, collaborative meetings, huddling. They all have extended hours. We're talking about how can we incentivize weekends, and I say incentivize, not mandate weekends. And then we want to put mission and formation into each one of the medical homes. We want the spirit of caring to be driven through primary care homes. And we'll talk about visual management. So these are all different processes that you're not used to having in your offices that build a team, that get the whole group working in the same direction, rather than saying, hey, Dr. Vandergriff, go do all this stuff because the system needs you to do it. That's not how we want to approach it. Now, when you look at the right side, that's all the new stuff. So Medicare wellness nurses, we have 10 of those now, and we're delivering care. Wellness and patient education. Many of you have seen our colonoscopy shared decision-making tool. So we're trying to give things to our MA so they can have intelligent, informed discussions with patients before you get in the room. Our RUA folks who help us with social barriers to care. And our psychiatry, which we're actually going to get off the ground in rural areas this year for intake and nurse practitioner psychiatry delivered into rural areas through a teleprogram. Working with pharmacists to be members of the team and manage polypharmacy, diabetes, etc. Our transitions clinics, which are now open in 5 places. Going to central scheduling, central gap closure that we discussed, and our nurse navigators. So this was the concept, and I really wanted to have you guys leave here today with a feeling of, okay, all this stuff is available now. This is stuff we can actually do. So let's look at that. This is a map of the middle part of the state, and when we look at our patient-centered medical homes, these are the actual sites we're at. So we're up, we're running, we've been doing it since last spring. Allisonville Road, Heather Glen in Indianapolis. We're up in Winchester and Anderson in the northeast. We're up in Frankfort in the northwest. We're down at Jennings and Bedford in the south. So we've covered all the areas of primary care in the state. And we're talking to Evansville about what they're doing. When we look at what we're doing in the spring, we're adding more in Indianapolis. We're going to the northwest region again in Kokomo and want to go to Greencastle. And we're adding in Central Carmel as well as more Anderson. So we've done this last spring, and this spring we'd like to start going faster. We'd like to start adding 5 to 7 practices in the spring and the fall. Dr. Purdy and Dr. Stanley, Dr. Tharp, Dr. Vandergriff are all, Dr. Emmons are all invested in helping us move that along, educate, do what we need to do to help people get to this. So we're growing those locations of patient-centered medical home, and then all those things that actually occur in the medical home are throughout the state as well. So nurse navigation is something that you have available to you. So we have a couple of things we're working on here. The mission point people, and we know that is our ACO, our MSSP that got talked about all through the first couple of sessions. Those are the people who proactively work the traditional Medicare population. You can see there's 44 people who work for Mission Point that call the patients after discharge. You can refer to them anytime you need them for that group. And then within our side of the house, those non-Medicare patients, traditional Medicare patients, we've formed our own group of navigation. And so we've embedded them in multiple sites. Anderson, Zionsville, Fishers, 4 in Indianapolis, North Vernon, and Evansville has 4. And then we have a central navigator as well. So if you don't relate to any of those areas where they can come to your practice, you can still get navigation through a phone call. So if you have a patient who's really sick, pre-hospital, post-hospital, and you don't know that they're going to get their medicine, that they understand their medicine, that they're going to get to their specialist, that they have barriers to care, navigation is one route that they can go, especially if it's clinical. When you look at what navigators do, this is a note from a navigator. Call the patient, post-hospital discharge, was experiencing increased pain, go into the ER. I offered the patient an appointment with the doctor. They missed the ER visit. That's what this is all about, is lowering the cost of care, lowering the ER admits, helping the patient, and helping you take care of that patient. We do this through a lot of different strategies. We use our own data, and essentially we use a data feed that tells us when certain patients are in the hospital or the ER, and we directly manage them. On that right side of the slide, I'll say I think the biggest take-home point I'd make on this slide too is we're working on a process for one referral. Because as we said, we don't want you to have to refer by payer. It's not what we want to happen. We want to have what we're working towards is a navigation referral, and then on the back end, we would actually then triage that out for you by insurance. So you don't have to think, oh, you're Mission Point, oh, you're Anthem, oh, you're this. We just want you to say, hey, this patient's sick and needs help. So we know that if they get navigated, we have a chance to keep them out of the hospital, make a navigation referral. So that's coming in the next few months is our hope. I want to go into a little bit of data on this. So as we started the navigation program specifically with our Anthem program, where they got phone calls on discharge and admission, we've seen they've driven attribution to us because we've done well and increased our number of lives by 10,000. We increased our quality score very significantly from a baseline of 47 to 64%. It's hard to understand what that means. Greater than 60 is really, really good. It's one of the best performers in the state. And then our potential ER visits are avoidable ER, so stuff you might not have to go to the ER for by diagnosis, has gone down over 30%. Our ambulatory sensitive conditions admissions, so this is like UTI, pneumonia, things you get admitted for that just by looking at the diagnosis, insurance companies think well, that probably shouldn't have been admitted, has gone down by almost half. And our HCC score has gone up, or has trended up. You do see some bumps in this because of attribution over time, but overall the trend of the HCC score is up for these patients as well. So we've seen some really good data and outcomes for these patients who are in a really large cohort, 72,000 patients, to show us that this is some pretty exciting work. So the other part of what we need is help with our social barriers to care, right? So patients who have needs that keep them from really accessing the healthcare system. So whether it be insurance or food scarcity, domestic violence, things like that. So what do we do with those problems? And how do we, more importantly, access those resources in a consistent way, right? So we know that somebody's really good at domestic violence somewhere in our region, but we don't really know how to consistently access that information for the management of that problem, right? And so what we want to do is have experts in each local area. As you can see in RUA, with RUA, Rural Urban Access Health Workers or health advocates, we've augmented that process across the state. You should have a RUA person you can reach out to who can help you with those issues. By growing that program and making awareness through the patient-centered medical home process, because we really lean heavy on that when we talk about patient-centered medical homes, we've grown the total number of pathway completions by 25%, and probably the referrals we think over 50%, because not everybody who gets referred completes a pathway. So we're touching a lot more lives and breaking down those barriers to care through this program, and we want to continue to do that. Our Medicare wellness nurses across the state, you can see we're in the central region of the state and also in the Northeast in Randolph, Anderson, and then also down in Jennings. You know, the Medicare wellness nurses are there to help you close those gaps in that Medicare population. They spend an hour with the patient and they go through everything there. They ask them their depression screen, they go through their fall risk. They find out that, you know, they're depressed and really have some serious issues sometimes because they take an hour with them. Or they tell them things that we don't find out in the time we're trying to get through a problem list of 17 things we have listed for the patient. That social issue doesn't come up. So it's a really valuable program. It's one that I think our providers like. When they come out of that visit, all those quality scorecard gaps are closed and you do really well. So we think it provides value for the patient, provides value for the provider. Our goal is to get them each up to 70 a month where they're at. They are shared across practices. We're going to double our Medicare wellness rate from 10% last year to 21, 22% as kind of where the final numbers look. We're going to be over 30% for 2017, and we want to be up to 50% as an organization in 2018. This is where care gaps get closed. Healthy Transitions Clinic, the work Mason's done is amazing, and everybody loves it. When they see it, they want to do it. So now we have it in 5 areas of the state. What Mason's done has been replicated now in Kokomo, Anderson, Evansville, and they've started an outreach clinic in Jennings. Other rural areas are looking to say, hey, can we do something like this for at least a small percentage of our population? And what do? They see those patients who are coming out of the hospital or pre-hospitalized or get turned over from navigation, and these highly acute patients, and help them stay out of the hospital. They've touched over 600 lives, and their referrals continue to go up. And I think the most important thing when you look at this slide is, this is a pretty impressive slide. Of the first 67 patients they followed, the 90 days prior to being transitions clinic, that same cohort had 35 readmissions. The 90 days after, they had 10. Their total cost of care was almost $4 million, dropped down to almost $2 million. I know your no-show rate's really high and it's frustrating, but the work that's being done there is really important. So we want to touch on other things that augment the care of your patient, and we drive and stress in the medical home. Remote care. We can do remote care for every patient in the state of Indiana and also in Kentucky, and we're working on Illinois. So, because we have patients down there in Evansville. These patients are often CHF, hypertension, MI. In 2016, they monitored over 2,500 patients, and they keep the great saves. So those are interventions that could potentially avoid hospitalization. And so these are sick, acute patients, and when we work with them, we keep them out of the hospital. So they can help your care, the cardiologist care, etc. It's really being leaned on in the CHF pathways, because we already do a great job with CHF, so how can we make great better is our question. Medical alert services, these are out, they're out there for you to look at actually today. We have medical alert services through St. Vincent's, and they come highly rated as the takeaway, and they do a very good job for your patients. So if you don't know where to get that medical alert bracelet, call us. This is another interesting thing that kind of puts that medical home and even goes to medical neighborhood concept. And Mason's question about transitions. We've actually identified SNFs that are skilled nursing facilities, to make sure everybody's up to date, that nursing homes that we find to be preferred partners. And so now you can know that we're actually going in there and talking to these people about their data, their quality. Are they in the right geographic area? Who should we send our people to when they get out of the hospital to get the best care? Also, when you put a patient directly into a nursing home, what's the best place for them? Where are they going to get great care? And more importantly, for primary care, when they come out of when they come out of there, one of their commitments is to send you a discharge summary, so that you know what happened to the patient and there's communication. So we're trying to make that a process that works instead of one that is often broken. Central scheduling is a reality. It started in December with our first sites. My site went live just recently, and my office really likes it. It's been really good. My front staff's very happy. They're asking me, what else? Can we do prior authorizations now? Can we start to do ER callbacks for you, which is a priority for our office? Because 100 phone calls a day are now going through the call center. So patients are getting what they want through the call center, but they're also getting services they don't know they're getting by us using that staff to do some new and different things. That really fits right in line with our strategy that we've worked on over the years. You guys know this stuff. The open access we put in a couple of years ago, the 72-hour follow-up we put in, the reliance on portal that we've had conversations about, the extra 2 hours and late hours that we've talked about, and now centralized scheduling, and what will come after that is online scheduling. Once you have standard schedules, you can do online scheduling through a pretty slick application that really looks good and markets for you. So that's to come probably in late 17, early 18. Pharmacy medication management. This is occurring in my office. It's also occurring in Heather Glen. We have a pharmacist who works with all of our polypharmacy patients and our diabetes greater than 9 patients. They have good data. They follow algorithms and they get outcomes. And so when I need to have more counseling, more time, more discussion with those patients, then I say go see Carrie, because I know that I can't. I know that I can't do it all at that moment. It's been a really good satisfier for patients, but it's also better for their care. Oops, that slide didn't come out real well, but that's outcomes at the PCC. So, and we can get to this slide, which is the MS with the patients they worked with. Their A1C numbers dropped from over 50 patients with an A1C greater than 9 to 15. less than 8 went from 23 up to more than 60. So you can see that these are patients who are already being managed, are already difficult, and taking that extra step with pharmacy started to make a difference for them. Our telepsychiatry services, we're starting in the next 2 months. Our goal's in April, and that'll be Randolph, Jennings, and Bedford. And we'll have a psychology intake with nurse practitioner delivery of psychiatry in those areas through a MacBook, or not MacBook, MacBook Pro. MacBook Pro? No. iPad Pro. There you go. So that will be the device. Did I say it right? I did, didn't I? Okay. So that'll be the device that they can actually manage the patients through. And deliver a service that's been really needed in those areas for a long time. Quality improvement, we're getting to the end here. Quality is our focus every day now, and it should be all of our focus every day now, and it's an entire state initiative. And we talked about the scorecards kind of at length. The other portion is this board up here, and so a lot of what I've talked about is how do we get everybody going in the same direction. And visual management boards come out of industry, right? You've probably seen them. And our 4 pillars are patient experience, quality, provider and associate experience, and stewardship. And so every month we can put your practice data on there and have a team meeting to say, hey, what are we working on this month? Our colonoscopy numbers aren't very good. Let's all work on that. MAs, let's ask that question when we were in the patient. Look at the shared decision-making tool. Front desk, maybe we can make 5 calls a day from the list of people who haven't had up-to-date colorectal screening. All that coming together to help you take care of your patient and engage the team. As I was talking to Dr. Ingram at the break, MAs and PSRs and now our transformation specialists, they love being engaged in things that help patients. You know, they're in healthcare for a reason. There's a reason they don't work down the street doing something else. And if we can have them be engaged in doing this work with us, they really like it. And it helps satisfaction, and it helps you, it helps the patient. It's a win for everybody. We have some specific educational materials, so we are working on engaging patients with this too. So we give these handouts. We're working on developing that more. And this is a quote I like from Alan Mulally, who's he was the CEO of Boeing and brought them back, and he went to Ford and he brought them back off at the brink, and they never went into they were the one company that did not go into bankruptcy during the bailout of the auto industry. And you know, he says a compelling vision, comprehensive strategy, and relentless implementation are the keys to success. And we want you guys to be involved to see all of that, the vision, the strategy, and then join in with us in the implementation as we go forward. So that's where we're at Patient Center Medical Home. For this talk, I wanted to bring up a different group, which is the people maybe you don't know. And so I'd ask that group to come on up for us today. So we have one of my PSRs, Heidi Smith from my office, Marion Kreitzer, who's a nurse navigator, Heidi Summers, who's our Medicare wellness nurse at Allisonville Road, Suzanne Engel, who kind of helps recruit and put some of those programs together. And I'm going to go ahead and step down and let these guys talk. I think what I wanted you guys to do is get a familiarity with who's on the team. What do they do, and what's different about what we're doing. So I know you guys aren't all totally used to speaking in public and those kinds of things, but if you could just go down the line and maybe introduce what you do and how it adds to the team, maybe how being involved in the medical home affects what you do. Okay.
Well, good morning, everyone. I'm Carrie Moore-Klein. I am a pharmacist here with St. Vincent and have had the opportunity to be at both Allisonville Road and Heather Glen. And as Dr. Shoemaker alluded, I see polypharmacy patients. We also work in a collaborative drug therapy management agreement with providers to see patients for complicated disease states. So we can see patients with diabetes, prediabetes, hypertension, heart failure, hyperlipidemia, and smoking cessation. And so we're kind of in a unique position, being able to work in a collaborative practice, in that we can not only spend that time, as Dr. Shoemaker mentioned, to really have more opportunity to provide education to patients about their medications and work with them on strategies to simplify and optimize adherence. But we also have the ability to help achieve outcomes by working off of physician-approved protocols. So with the value I think that we add to the practice, it's just really having that opportunity to sit down and have that time to engage with the patient, to work on adherence strategies and help to achieve disease state outcomes.
Great. Suzanne, you might mention kind of how you choose people to go into the medical home too, like because you do a lot of the hiring, and I know that as we with our nurse partners, so you might mention that as well.
Okay. Well, I'm Suzanne Ingold, the Director of Care Coordination for the second time. And I started the navigation and the Medicare Wellness Program here at St. Vincent Medical Group with the intent to really serve our patients that are highest risk, highest need within the medical group, and try to decrease their cost of care, increase their well-being with both the Medicare Advantage patients and any of them, but with both the Medicare wellness nurses and the navigators. We really looked at where the highest concentration of these patients are. We selected medical homes to place these people, and then I started searching for people that had the same passion I did to take care of these patients. And I have the best people ever. And my job is so great because they love their jobs. So that's what I do.
Very good. Now, Heidi, you've been with us before Patient Medical Home and after. So, and maybe what you see is different, and what you like, what you don't like.
I am Heidi Smith. I'm the patient service representative and the change leader for Allisonville Road North. I have been here 13 years. So we just went live a year ago, exactly almost, for our PCMH at our location. What I noticed is the whole team basis. We have all the providers and the staff, front office and back office, so clinical and non-clinical, that huddle every day before we start our load of patients for the day, going over workflow, what everybody does, any scenarios that we might have with the patients. We try to make sure that we have everything that we need to serve the patients when the patients come in to see us. So we have the whole team go through and pull up any documentation that may be needed before the patients are there.
Very good. And we've survived centralized scheduling and implementation?
We have survived centralized
Okay.
scheduling thus far.
Very good. Heidi, one of our Medicare Wellness nurses.
Good morning. I'm Heidi Summers, Medicare Wellness Nurse. I am at two Fishers locations, Allisonville Road North as well as St. Vincent Northeast. And I've been with St. Vincent Medical Group since May, but I've been with St. Vincent for a really long time. I recognize a lot of faces here in the crowd. The annual wellness visit that I conduct, I just try to encompass all, of course, the critical points, which includes the depression screening, the memory screening, and the falls risk assessment. But I mean, the great thing is that we get to spend 60 minutes with these folks, and there's a lot that comes up during the annual wellness visit that maybe some of the providers don't have a lot of time to spend discussing with patients. So it's just a great opportunity. I love the patient population, the 65 and older set, and it's a great opportunity to really help identify some things that maybe get overlooked or the providers don't have time or a chance to address when they're with the patients. We can also address a lot of the different quality measures like the colon cancer screening, mammography. If there are any barriers to people doing their screenings on time, we can try to identify what those barriers are. We can also do a lot of medication reconciliation and figure out what barriers to adherence to medication regimen might be. So it's a great role, and it really affords us the opportunity to spend time with the patient.
Hi, I'm Mary Ann Kreitzer, and I'm a nurse navigator. I have the good fortune of working at the Harcourt Primary Care Office. Patient navigation has been in place for about 4 years now. We started 4 years ago, and we work a lot with the transitions of care with the patients, emergency room follow-up phone calls, ensuring that those patients have their follow-up visits scheduled. We actually go to the hospitals, the respective hospitals, and meet those patients and families in person. And I think one of the most important things about navigation, number one, is making that connection, and number two, establishing a trusting relationship with those patients and their families. And I think number three, and what we do every single day, is a relentless commitment to make sure those patients and families have their needs met. It's a great feeling every day driving home on I-69 knowing that you've helped someone in some fashion that day. So, like Suzanne said, it's a great job. And I want to quote one of our greatest cheerleaders for navigation, Dr. Fogel, "Navigation rocks."
Hey man, who do they call? What happens at 7, 8 o'clock at night if the patient you're navigating and they're not sure what to do?
Well, we always instruct them if it's a non-emergent situation, just to leave a voicemail, and we'll get back with them first thing in the morning. If not, then they would call the on-call, depending on the situation. If it's an urgent matter, obviously the on-call physician, or sometimes they end up, going to the immediate care or emergency room. It just depends on the situation.
Very good.
I do feel like we've made a huge, huge impact on reducing those, well, we can see in the data we have, but just doing that follow-up phone call and identifying those needs, i.e., a good example would be impending results that are not yet at the office, and going back into Sunrise Clinical, getting those results to the physician prior to the appointment has been a huge impact, I think.
Great. Well, I think as we've gone through this, we're learning all the time, and we're getting better at what we do. And now when you go, if this doesn't sound familiar to what you've done, we've had those lessons learned, and we have people who can teach and mentor and help implement the process as you go forward in your practices. So, we put ourselves, Mike and I put ourselves on centralized scheduling first for a reason. So we promise not to do anything to you that we wouldn't do to ourselves. So thank you guys.